Hi, I'm Dr. Alana Morris. Welcome to our second in a series of heart failure podcasts, Translating Data to Patient Care, a case study in HFrEF. This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. This activity is supported by an educational grant from Merck, Sharp, and Dome Corporation. As mentioned, I'm Dr. Alana Morris. I'm an associate professor of medicine in the Division of Cardiology at Emory University School of Medicine and director of heart failure research at the Emory University Clinical Cardiovascular Research Institute in Atlanta, Georgia. I'm pleased to be joined again by Dr. Javed Butler, the Patrick H. Lehan Chair in Cardiovascular Research, professor and chairman in the Department of Medicine, and professor of physiology and biophysics at the University of Mississippi Medical Center in Jackson, Mississippi. Welcome, Dr. Butler.
Great to be with you again, Dr. Morris. Look forward to continuing discussions.
Let's begin with our two learning objectives. After participating in this activity, learners should be better able to individualize treatment plans for patients with HFrEF that reduce readmissions, improve quality of life, and optimize long-term outcomes. And recognize the prevalence of HFrEF in communities of color and address barriers to optimal care. So let's start with the case and meet Curtis. Curtis is a 75-year-old retiree who was hospitalized for HFrEF about 6 months ago. He has type 2 diabetes, mixed dyslipidemia, and hypertension. He was a smoker in his 20s and 30s. He smoked about a pack a day, but he quit. He currently drinks about 1 to 2 alcoholic drinks per week. And he comes to us reporting dyspnea on exertion with very limited activity, like walking up the 4 stairs that he uses to get in his house from the garage. The current medications that he's on are atorvastatin, metformin, carvedilol, lisinopril, spironolactone, isosorbide, and hydralazine. Dr. Butler, do you have any comments about these medications at this point based on the clinical history that I've given you so far?
Well, I mean, there's a lot to discuss here. He is on a reasonable medical therapy, but not exactly guideline-directed medical therapy. We don't have information on the doses or his sort of basic hemodynamics. So maybe there are opportunities and things to discuss there as well. And then finally, he may not be an optimal medical therapy to begin with, but the fact that he had a hospitalization 6 months ago brings a little bit more of a twist about this issue of added need for optimizing therapy and worsening heart failure. So lots to discuss.
Absolutely. And one of the questions I was thinking when I saw these medicines is I wonder if these are the medicines that he was admitted on and he got discharged on the exact same regimen, but we can come back to that. Let's examine Curtis. He's 5'9". He weighs 209 pounds, and that equates to a BMI of 31.2 kilos per meter squared. His blood pressure is elevated and suboptimally controlled at 148/91. He is tachycardic with a heart rate of 102 beats per minute. He's breathing 20 breaths per minute with a temperature of 98.6. He is edematous with 2+ pitting lower extremity edema. He has an S3 gallop, as well as evidence of bilateral rails at the lung bases. Does this physical exam point you in any particular direction, Dr. Butler?
Now you have really got me worried about this patient. So in some way, sort of the only thing going for him is that his blood pressure is uncontrolled, because a lot of these patients actually tend to be hypotensive, except that our African-American patients tend to have a little bit more blood pressure, so it gives us some freedom to give some extra medication. But the fact that he is tachycardic and has an S3 gallop, we not only need to make changes, but we need to make some changes fast, because he can get pretty sick pretty fast.
Absolutely. When we look at his laboratory findings, his total cholesterol is about 162. He does have a low density lipoprotein of 75. His A1C is 8.1. He does have relatively preserved renal function with a GFR of 80. His potassium is 4.1, creatinine 0.8. He has an NT-proBNP that's elevated at 1217. an EKG or ECG that's unremarkable. He has a chest X-ray that shows cardiomegaly and mild bilateral pleural effusions. And we do have an echocardiogram that shows us that his ejection fraction is reduced at 28%. So again, I think we've already identified, based on our history and physical alone, that Mr. Curtis is fairly high risk. But now we have some objective laboratory as well as imaging findings that really confirm. So I think that sort of points out a couple of things. Number one, heart failure is a clinical diagnosis, and I think we shouldn't forget that. Of course, we have access to many very sophisticated laboratories as well as imaging studies. But again, heart failure is a clinical diagnosis. And now we have the imaging to sort of confirm what we already suspected. So how does this help you? How does this change things for you, or does it change anything at all?
Yeah. So again, lots of very interesting things to discuss in this particular case. We don't know what his ejection fraction used to be and whether it is sliding down or not. And it used to be maybe 35 and now it's 28. But honestly, it doesn't really matter, even if it was 28 before and it's 28 now. Clinically, as you mentioned, it's a clinical diagnosis and he's definitely getting worse. GFR of 80, sure, like the blood pressure of 148, it just gives us some opportunity to give him more medications. But remember, he's a patient with diabetes and he is overweight. He has two reasons to be a hyperfiltration of his GFR. So 80 is already showing us sliding down. So again, we just need to keep that in mind, that that does not necessarily mean that all of these conditions are not affecting his kidney. And then you mentioned his NT-proBNP level is high. Again, it's because of his obesity, it's probably even higher. Yes, I realize that the hemoglobin A1C control may or may not have an impact on his heart failure outcomes. But if you look at the totality of care for his kidneys, for his eyes, and for the things that diabetes needs to be controlled. So bottom line is, we need to control his blood pressure better. We need to control his diabetes better. We need to keep an eye on his kidney function. Honestly, even with a GFR of 80, I would still check and follow his microalbuminuria and just make sure what is going on in that sense. And then finally, there's a ton to do for optimizing his heart failure care.
Yeah. So, when I see patients in clinic, I usually try to document their ACC, AHA stage at every clinic visit, as well as their NYHA functional class, because we know that the functional class really does change many times from visit to visit. Certainly for some patients who are very refractory or who are quite sick, it can change much more rapidly than that. I would say Curtis certainly is at a minimum stage C. And I think, in some cases, we might even have some concern that he's approaching stage D, but we won't go there quite yet. In terms of NYHA functional class, what do you think? I think he told us that he was having difficulty walking up the 4 stairs that it took to get from his garage into his house. How would you classify his NYHA functional class? And does that matter? Do you do that every time you see a patient as well, or?
So this is, I sort of smile because this is the case where the clinicians make up designations, things like class 3B, because you don't want to call it class 4, but he's really sort of getting there and he's not exactly the class 3 that we think about. This guy is sick. Yeah.
Mm-hmm. Yeah, absolutely. So let's talk about pharmacotherapy, because we saw earlier that Mr. Curtis is on, let me just remind you, atorvastatin, metformin, carvedilol, lisinopril, spironolactone, and isosorbide dinitrate and hydralazine. I'm not super thrilled with this regimen. I'm not sure how you feel, but tell me, what are your thoughts in terms of, is there room to optimize his medical therapy? And if so, how would you do it? Where would you start? And what would your goals be?
Yeah, so there are certain things that are really easy, and one thing that I'm sure that you and I will have a pretty robust discussion about what to do. So the really easy things are, his blood pressure needs to be controlled, but we don't need to control blood pressure. If he optimizes heart failure medications, overwhelming chances are that his blood pressure will get controlled. Of course, we need to worry about comorbidities, so just make sure something else is not going on, that he has developed hypothyroidism, he has raging iron deficiency and all that kind of stuff. But that's all just sort of good practice. repeat the echocardiogram, make sure that he doesn't have, the torrential mitral regurgitation or aortic stenosis. Again, all sort of common sense things. But then let's talk about his pharmacotherapy. So he's on carvedilol, he's on beta blockers, his heart rate is 102. That's a really high heart rate. So assuming on EKG that he's in a normal sinus rhythm and not in atrial fibrillation, first, we don't know what his carvedilol dose is, but definitely needs to be optimized. And even in my opinion, with the blood pressure being on the good side, if his heart, even if he's on target doses of 25 BID of carvedilol, honestly, I would go to 37.5 BID and he would go to 50 BID. His heart rate should be really at least in the 70s, preferably in the 60s. And if that doesn't work or he's unable to tolerate beta blocker and he's in sinus rhythm, then ivabradine is also an option. I think his ACE inhibitor really needs to go, and he needs to be started on valsartan sacubitril for sure. He has good creatinine, good potassium. So if he's on some sort of a cosmetic spironolactone dose like 12.5 every third day, that needs to be optimized as well. Both for his diabetes and for his heart failure, SGLT2 inhibitor is a big consideration for him. And then very CGUAT for worsening heart failure is also an issue. The challenge here is that he is on hydralazine nitrates. And suppose if you're unable to optimize beta blockers because he's on hydralazine nitrates, what do you do to compromise hydralazine nitrates? There are data with African Americans. So let's discuss that a little bit more further down. But these are just some of the initial things that we need to consider.
And I also find it interesting that Mr. Curtis is not on a diuretic because he's a demonist and because he was hospitalized 6 months ago, which of all the things that he's not on is sort of surprising to me. It's almost wow. So would you diurese him before you, initiate and titrate those medications that you just mentioned? And is there a role for diuresing him and getting him euvolemic before you titrate those therapies?
So great point. I missed that. You're 100% right that this is absurd that this person would not be on sort of loop diuretics, and he definitely needs loop diuretics. Honestly speaking, again, I'm hearing about this case. I'm not in front of the patient. This is the kind of patient that you might just want to even admit to the hospital when you see him. But if you're trying to manage him in the outpatient, I think initiating loop diuretic is for sure. I probably wouldn't wait for him to become euvolemic before start making changes. And I would probably make one change right away along with initiating loop diuretic. Now, whether that one change is switch from lisinopril to valsartan sacubitril or adding an SGLT2 inhibitor or something like that, we will all have our individual preferences, but I would probably start loop diuretic and make one medication change. But the big other thing is, this is not a person that you make two changes and say, I'll see you back in a month or I'll see you back in 3 months. This is a person that needs to be seen next week.
Absolutely, absolutely. So I think you brought up a number of really good points, again, that we want this Mr. Curtis to be on sort of foundational therapy, the Fantastic Four, if you will, quadruple therapy, which he's not on. So I agree, I would probably switch out his ACE to an ARNI. He was on a beta blocker, but the question is whether or not there's room to titrate that to improve his heart rate. The SGLT2 inhibitor, I agree, is something that he needs because he has type 2 diabetes, because he's volume overloaded. There's just so many reasons because of his CKD. And of course, the mineralocorticoid receptor antagonist, as you mentioned. And then I think you're absolutely right. Of course, we had this indication for hydralazine isosorbide dinitrate because he is African-American. And the question, of course, is how to do this, particularly in patients who had previously been on the drug, as opposed to patients who were on 4-drug therapy and perhaps are still hypertensive, and then we're adding this as an additional agent in patients who remain hypertensive. And I think that there's still sort of controversy, of course, in my clinical practice, because of where I practice in the country. I mean, your practice, I'm sure, is very similar. Most of our patients are probably in the scenario where they had previously been on hydralazine and isosorbide, and we're trying to figure out how to add drugs to that regimen and whether or not we should stop it in order to make room for SGLT2 inhibitors. And it's not always clear to me how to do that, to be honest with you.
Yeah, so I think what I'm about to say, I'm sure that some of our colleagues may or may not totally agree with that. So first of all, the use of Bidil or the combination pill is incredibly low. Most of the time, the hydralazine nitrates are a combination, and you're giving a twice a day medication. Compliance is an issue. That's one thing. And then the second thing is that polypharmacy is another issue. But the third thing is that we sometimes forget that the AHFT trial was done in people with persistent class 3 symptoms despite optimal medical therapy, whereas all these other trials that we're talking about were included all symptomatic patients. We also know that about 70% of the patients are class 2 and about 25 or so are class 3. So the majority of the patients on optimal medical therapy become class 2. So the question here is, do we add medications to his regimen, or at some point, to simplify his medical regimen, have sort of a switch mentality that as you're going up on valsartan sacubitril, as you are going up on the dose of beta blocker, for him to be able to tolerate other therapies more and can get into optimal medical therapy to decrease polypharmacy, should we actually taper it off and see on the standard of care foundational therapy, if he can get to NYHA2, then maybe he does not need that. But I'm sure that different people may have different opinions.
Absolutely. I mean, I think one of the keys, though, of course, Mr. Curtis is representative of many patients that we see, again, in our clinical practice. He's African-American, and his risk for poor outcomes is extremely high. We know that the rate of heart failure hospitalization is highest for Black patients, and that oftentimes their medical therapy, for whatever reason, is not titrated as optimally as it could be. And I think it's important for us to sort of acknowledge that, because race and ethnic inequities in medical care are really pervasive. For a variety of reasons, studies have suggested that as clinicians, we spend less time talking to patients of color. Our visits are shorter, they're less patient-centered, and oftentimes we don't necessarily engage in shared decision-making with patients of color in the same way that we do with white patients. Whether that's related to implicit bias, whether it's related to assumptions about whether or not patients can afford some of these newer drugs, which are more expensive. Maybe our preconceived notions are more likely to impact patients of color as compared to other patients. But it's important, right? Because we know that patients of color, particularly Black patients, have the highest risk for poor outcomes, like high rates of hospitalization, high rates of mortality. And so we really have to sort of improve our efforts to optimize outcomes in this group in particular.
Dr. Morris, can I add one more thing to what you said?
Yeah.
That is something that really, really bothers me. So, I mean, you've already said more than enough that should bother us, right? So higher risk for outcomes and not getting optimal care, and there are all these sort of racial disparities. But sometimes I've also heard people say, well, part of the reason why these patients are not on optimal medical therapy is because the clinical trial enrollment or representation of minority population was very small, so we don't have as much as a robust database. And this really bothers me, because now this is double jeopardy, because there are these socioeconomic differences between different groups that makes it difficult for them to participate in the clinical trial. And then you hold it against them that there was not robust participation in the clinical trial. So first, 100% agree that we should do whatever we need to do to be able to have more minority representation in clinical trials and more women representation in the clinical trials. But unless and until there is very good biologic reason to suspect that something is going to be ineffective in Black patients, we cannot have this double jeopardy that there are social reasons for which they are unable to participate in clinical trial, and then we don't give them the therapy despite having no good hypothesis why they should not be treated.
Absolutely, absolutely. And it's interesting because we've seen that in AHFrEF, for example, where we did the trial in this group, we still saw underutilization of the drug. So I think we have to sort of acknowledge that as clinicians, sometimes we do not follow the data and we do not follow the guidelines when it's staring us right in the face. That our patient-provider interactions sometimes are just not optimal when it comes to patients of color.
No, completely agree.
So there are other options. Of course, we talked about foundational therapy, quadruple therapy, which again, Arnie beta blocker, MRA, as well as SGLT2 inhibitor. There are some other new kids on the block, I like to call them, like vericiguat, for example, that we could maybe think about in a patient like Mr. Curtis to avoid a rehospitalization, because he has had a hospitalization in the past 6 months. So I think we could sort of classify him as someone who's high risk, someone who's had worsening heart failure. Would you consider adding an agent like vericiguat to his regimen?
Yeah, so, one really good problem we have right now in many chronic diseases, diabetes, chronic kidney disease, heart failure with reduced ejection fraction, is that there are so many new trials that have come out, and thanks goodness that they are all positive trials, that these trials are not done incremental, right? From 1980s to 2010, we sort of had ACE inhibitor, and then we added beta blocker, and we added MRA, and now these trials have been done parallel. So the question comes up about the incremental benefit of starting this and that together. So in the absence of clinical trial, the question is, how do we make the decision? And at least in my perspective, there has been no trial where if you have an independent pathway, not overlapping pathway like giving ACE inhibitors and ARB together to a patient, but when there are independent pathways, that the benefit is related to underlying therapy. So for instance, ARNIs work whether or not you're on MRA. SGLT2 inhibitors work whether or not you are on ARNI. So these are independent pathways. So the question here is, in this particular case, that do you optimize foundational therapy and let the patient fail again and then start vericiguat, or this patient is sort of failing enough and that we should start the therapy sooner so that we give him the best shot. I'm sure that there will be different opinions on that, but at least my opinion is that this person is sick enough, has met the criteria for worsening heart failure, that starting these therapies early to change the trajectory of the disease would be very important.
Sure. So I think, it's important, and let's assume that we've talked to Mr. Curtis and his family about all of these possible therapies, and that we do our due diligence in clinic and rapidly, but over time, sort of optimize these therapies. And talk to him also about the importance of adherence to keep him healthy and hopefully keep him out of the hospital. We haven't really talked about the role of devices, but of course we know that there's relatively good evidence for device therapies, including, for example, the pulmonary artery sensor that we've seen recent addition of evidence for. We also know, as we've talked about, there are disparities for device therapies in patients of color, so I think it's important to point that out. We could, of course, refer Mr. Curtis to a dietitian if he needs counseling on, again, lifestyle strategies to maintain a heart healthy diet or a low sodium diet. And as you mentioned, making sure that we see him regularly to ensure that he's tolerating these therapies, that we're titrating these therapies where we need to make sure we get his blood pressure down, optimize his heart rate, and that we add therapies if he continues to have refractory symptoms. So I want to thank you so much, Dr. Butler. Again, this has been such an exciting discussion about this case. Let's summarize by reviewing our SMART goals, which are, again, specific, measurable, attainable, relevant, and timely action items that hopefully you can take back to your practice. We want to use an individualized, patient-centered approach when diagnosing, stratifying risk, and treating HFrEF. We want to establish and maintain guideline-directed medical therapy in all patients. We want to switch and or augment therapies as needed based on patient preferences, medication tolerability issues, and evidence-based sequencing, including the use of newer agents. We do want to consider the potential for implicit bias when treating patients from communities of color, but really to ensure that equitable treatment is applied for all patients with HFrEF to improve clinical outcomes for these patients. Again, thank you so much, Dr. Butler, for an insightful discussion today. And thank you, our audience, for joining us. Please follow the instructions on the web interface to receive CME credit. And if you haven't already seen it, please check out the first episode in this series, Managing Patients with HFrEF Post-Discharge, Discussion of the Latest Evidence. And please stay safe.